Good day and welcome. I'm Shirley Fenton, Managing Director of the Waterloo Institute for Health Informatics Research. Thank you for joining us here today and via the webcast for the final seminar in the eHealth Strategy series. This has been a wonderful series which has allowed us to explore in some detail eHealth strategies in Ontario and across Canada. We began by looking at Ontario's wait time information system. We've looked at initiatives to share digital images, the implementation of the Ontario Laboratories Information System, and have reviewed our progress in moving to electronic health records. We've heard about data problems, the need for eHealth strategies in home care, public health, and psychiatric care. We've mulled over issues around the physician and eHealth and approaches to engaging them in eHealth strategies. Today we'll learn more about advanced hospital systems in terms of eHealth strategies, and this will conclude our series. These lectures have painted a picture for us where we are and where we're headed, and there is still a lot to do. Hopefully, however, these seminars have helped at least in understanding the problems and the issues that we need to address. So, a special welcome to our speaker, Matthew Anderson. Matt has several titles. I always have to look at these titles to appreciate them. He is the CIO of the SIMS Partnership, the eHealth lead for the Toronto Central LHIN, and he's also Vice President of the University Health Network. A special thank you to our seminar series sponsors, Borden Ladner Gervais, McKesson, Health Information Management and Communications Canada, Smart Systems for Health Agency, and of course RIM, better known as the BlackBerry. Just to let you know, we'll do the draw at the end. Before we start, I just have a quick announcement. Our new series next year is in honor of the university's 50th anniversary. The series will be called Why Not?, after the university's anniversary theme. We have an impressive list of speakers coming, and the series will be kicked off by Dr. Jake Thiessen, the director of our new School of Pharmacy and our new Health Sciences campus. And just to let you know a little further ahead, in September, we have Senator Michael Kirby as our guest speaker. So without any further ado, I'll let David Johnson, the president of the University of Waterloo, introduce our speaker.
Shirley, thank you very much. It's a delight to welcome Matt Anderson here to our campus. Shirley has given a brief introduction of Matt. Let me just add a few things. Matt is a graduate of the University of New Brunswick and the University of Toronto. Went to the University of New Brunswick because out of high school was interested in a program to combine preparation for teaching as well as math and computer science. Again, it shows the wisdom of having attractive programs to draw outstanding students from across the country. Matt says he didn't end up going into teaching, but in fact he has, because you're a coach and a teacher and a mentor par excellence in your current responsibilities, Matt. Shirley has given you some of Matt's titles. I'm not sure all of you have seen the brochure advertising this address, but I'm struck by a number of things. So one is the cluster of activities that Matt is responsible for, 7 different hospitals or health administration units, and of course that very large one, the University of Health Network. There's a message in that, the clustering of activities, the Chief Information Officer embracing a number of entities, and how important is it that we get it right at that bellwether set of institutions, beginning with the University Health Network in Toronto, because if we get it right there, the chances are we'll get it right across the country and around the world. Matt was also saying that he hires about 20 Waterloo co-op students each term. And those of you in contact with students, or those of you who are students, please get the word out. We really should have 2,000 or 3,000 University of Waterloo students each year going into co-op terms in health informatics placements, because the excitement of what is happening at these institutions in health informatics is enormous, and we simply must do more to be sure we're supplying our talent and matching them with these great opportunities. Matt is also a top 40 under 40. Matt, we kind of cherish that award and that achievement here. Most of you will know that each year we recognize in Canada the top 40 people who have achieved great leadership distinction before their 40th birthday. Matt was one of those in May '05. In the very first cohort or group was our current board chair and campaign chair, Bob Harding. I think the second cohort was Amit Chakma, our provost. And I think since the program began about a dozen years ago, I think there are 23 or 24 University of Waterloo graduates who've been top 40 under 40. And we had many of the Waterloo top 40 under 40 graduates with us for our homecoming about 4 or 5 weeks ago for a special morning on leadership. Matt, we invite you back to that as an adopted University of Waterloo graduate next time. It's a pleasure to welcome Matt Anderson here, and we're thrilled that he will be explaining to us some very interesting things about advanced hospital systems and eHealth, and will continue to recruit and engage these Waterloo students and graduates. Matt, over to you.
Thank you, David. Thank you very much, and I can say shamelessly that the main reason why I take these gigs is because we want to recruit as many people as humanly possible, and Waterloo has been very, very good to us. Sort of brings me down a old Saturday Night Live skit, but I won't. Baseball has been very, very good to me. So Waterloo has been very, very good to the University Health Network. Many of our top leaders now within SIMS, which is the Shared Information Management Group, come from Waterloo, and from all disciplines, by the way. We recruit arts, and I do have to tell you that although I went to the University of New Brunswick to study math and computer science, I came out with a degree in English. And I'm still a CIO. Yeah, that's arts people, and I'm thrilled that I've got a job that doesn't involve me asking if you want more fries with that. So I'm going to walk you through a few slides. I've been asked to go through the presentation. It'll probably take me about a half an hour or so. I'm going to try to watch the clock a little bit, only because I'm like Dominic, I could go on forever on these topics. So. But I did want to just take you through a few things. I do have all these multiple titles, which is not a new thing in healthcare, and certainly not in an academic setting. I'm sure many of the professors at Waterloo have multiple roles and have multiple titles. I'm not going to spend a tremendous amount of time on the vice president role or the LHIN eHealth role, although I'm very happy to talk about eHealth in the context of the LHIN. We just recently got our strategy document approved, so I don't have any of those slides in here, but I'm very happy to take questions on that should you be interested. Most of my chat will focus on the SIMS partnership, and then trying to put that into context of some of the things that are going on really across Canada in particular, and also in other countries, and how that's influencing some of our decisions as we move forward. This first slide is a little shot of the Toronto Central LHIN. Actually, and since the time that we sent agreed to participate in this program, 2 more healthcare organizations have joined into the SIMS partnership. Providence Healthcare, which is a long-term care organization and rehab organization, and Women's College, which is an ambulatory care facility, also an academic center, which has been interesting and great to have another academic organization join us. Some of the important things about this partnership that I just wanted to highlight for you. First is maybe down in the bottom right corner here, that $1.5 billion is the transfer payment total that comes from the Ministry of Health to these various healthcare organizations. Okay, so it doesn't include foundation revenues and other sources of revenues. If we include other sources of revenues, then the healthcare agencies involved in the partnership pretty close to $2 billion of total revenue. Okay, which gives us a reasonably good size for trying to launch some of the strategies that we want to launch. And it's been a lesson for us that's, in my mind, absolutely clear, but unfortunately is not gravitated throughout Canada yet. Canada is a relatively small market. The vendors here would understand this very, very well. It gets even smaller as you break that down and segment it more and more. What we're trying to do, one of the things that we're trying to do through the SIMS partnership, is present these healthcare organizations to the market in a collective way to try to achieve that critical mass and maximize savings as we go through this. I would point out that the University Health Network is about $800 million of that $1.5 billion, and University Health Network at $800 million found itself in the position where we felt we were too small to actually wage a significant play into the eHealth world. One of my little lessons on that one was we're a big customer of HP. Actually, we were a big customer of DEC, and then DEC got bought by Compaq, and Compaq got bought by HP. So now we're a big customer of HP's. And there was a site visit that they had asked us to do where HP, at the time I think it was Compaq, was bidding on some business down in the U.S. with Citibank. So Citibank wanted to do a site visit. Citibank came up, and there was little me, and they sent up 7 of their vice presidents, all of them very tall. It was very intimidating. It was very intimidating. And I presented myself and talked about my 7,000 workstations and, with the largest, at the time, the largest healthcare network in Canada, 7,000 workstations on a single LAN. They went around the room, and as they introduced themselves, they said how many workstations they were responsible for. The smallest was 25,000, okay? So we had 25,000, 30,000, 50,000. So if you just think about this on a pure business basis, forgetting about all the other dynamics, if you are a business person, you have an A team, you have your best team. Where are you going to put your best team? Are you going to put your best team on the contract that manages 7,000 workstations or the contract that manages 150,000 workstations? Okay? So this is what we're up against when we're trying to do some of the things that we're trying to do, and why even a UHN at $800 million operating is too small to go to try to do this by ourselves. The other key thing that we had in here was the issue of staff training and retention. And I was lamenting to my friends and hosts at lunch today from RIM that oftentimes we found that we were nothing more than a training ground for consulting agencies. So we would get them from Waterloo, we would train them up, they'd be a couple of years with us, and of course most of these people, particularly folks who come out of Waterloo, hyper-competitive, hyper-ambitious, always thinking about what's the next thing. And as an organization, even the size of UHN, we had challenges in always providing a next thing. Because once you do a project that's sort of this big, you don't want your next project to be this big. So we were having some challenges, and what would happen is we would have people come in at the UHN, which is a group of 3 healthcare organizations in the city of Toronto that provide clinical settings from family practice units right through to some of the most high-end neurological procedures being done in North America and everything in between. When you have staff working in that environment, they're very attractive to consulting agencies, right? Because now a staff person's learned in these environments, and then they go and they work for these consulting agencies. So one of the things that we wanted to do was create an environment that allowed us to retain staff longer. By having an environment such as this, where we have community setting, long-term care, mental health and addictions, heavy acute care, we're able to offer people other things to do and keep their imaginations, if you will, engaged in the process, as well as giving us enough critical mass that they can see growth opportunities. One of the things that's interesting about this particular partnership, it's a trust relationship. I'm going to quote George Bush 2 times in this presentation, and neither of them will be cracking a joke. One will be the partnership, the coalition of the willing. This is a coalition of the willing, hopefully with a little more success than the last coalition of the willing. But all of these organizations have come together. We didn't go to any organization to sell this. We didn't go to boards to sell this concept. Instead, this started with the Toronto CCAC and the University Health Network, and organizations have seen the wisdom of what we're doing, and they're calling and saying, hey, we want to be part of it. Part of it specifically is that I'm appointed as the CIO at each of these 9 organizations, with full signing authority that would go with that position within that organization. So we do not position SIMS as a vendor. SIMS is, and we're struggling with it a bit, but SIMS is the internal IS department for these 9 organizations. That's how we're trying to position ourselves. So we're still doing business with a vendor. We wouldn't bid on RFPs. We release RFPs. We may, the only difference is that we may release an RFP one day under the auspices of UHN, and the next day release it under the auspices of West Park Healthcare, for instance. Okay? So it's a very different sort of relationship, trust-based. It's also based on clinical relationships. One thing that we learned the hard way was trying to do partnerships that were based on business metrics alone, didn't have clinical impact. We couldn't even demonstrate clinical impact. They inevitably failed. They mostly failed because they, again, failed to capture the imagination of the clinical communities. And when we went in front of boards, we had a hard time, particularly the smaller healthcare agencies. These volunteer boards are there because they care about their community, and they care about patients, and they care about their clients. If you can't present back in those kinds of terms to them, it's very difficult for them to get excited about your initiative. In this initiative, it's all about clinical relationships and moving things forward. The last comment that I'll make, and I don't know who's on the other end of the webcast, so I've got to be a little careful, but one of the things that we also looked at here, and the significance of the box on the top left side, given that we are now about 1/3 of the total spend in the Toronto Central LHIN, but more importantly, because all the standalone rehab facilities are part of SIMS, and with the recent realignment of the community agencies, 100% of the community health population is in this SIMS partnership. You can't help but have to deal with us. So when we are just an acute care facility, other acute care facilities or other organizations can avoid dealing with us. Here they can't, because whenever they're trying to refer their patients out, they're going to be referring them to long-term care, to rehab, or to a CCAC, and there we are. So, and the purpose of that is not because we are a bunch of megalomaniac control freaks. We in fact are that, but that's not why this is the way it is. It's more because we're looking at leverage points to try to drive standards and commonality across the Toronto Central LHIN and hopefully a bit beyond. We're trying to do two things within SIMS, and this very simple diagram is probably the most important concept around SIMS, and I have to ingratiate myself a little bit to Dominic Covey because the recent OHA survey is one of the first documents that I've ever seen that has actually captured the concept that I'm going to try to describe to you here. In this slide, the Transforming Healthcare Delivery, which is the tagline for SIMS, our argument is that you can't just work in one of these two spheres. You have to do both together. You have to build, on the far left-hand side, you have to build capability within each organization to be able to actually use the eHealth tools that are provided to them. And on the right-hand side, you have to be able to build these tools in such a way that you can integrate and exchange information across the system. And what we've seen historically, particularly in Ontario, is very little overlap between these two circles. And my example would be that at the University Health Network, we're very proud of the things that we've been able to do in terms of putting in electronic tools. But up until the last 2 years, we couldn't exchange information with anyone. So it was wonderful once you were in the building, all of that information became available to our clinicians. But information prior to you arriving or information after you left was going nowhere. It would go back to paper again, and we would have the same process problems that exist that plague the healthcare system, regardless of this wonderful investment. In the case of the University Health Network, the management came to the realization that we can only improve quality, safety, and efficiency so far as just an island of information. You get to a certain place where you really need to be branching out and extending beyond that. Okay? Examples on the integrative, anybody who's been around healthcare can think of the number of examples. The Ontario Lab Information System project, which has presented here, is a great example of a wonderful initiative, potentially very powerful. But we need to figure out how it's going to integrate into what is in the existing organizations. And the OHA survey, going back to my opening comment on this, is the language that was used in there around being ready to participate in these eHealth strategies, critically important that these healthcare agencies are ready to go. One of the things that's really bizarre from a mentality perspective is the number of meetings that I'm in, particularly since my role with the LHIN. I tend to spend a little more time up at the Ministry of Health than I used to. And the number of times that I've been party to conversations where I'm sitting with folks, typically from the ministry, not always, people who are driving some of these integrative projects. And they'll be saying, well, we've got to get this project in, and they'll hear back from the field, it's not at the top of our list of priorities right now. And the response back will be, well, to hell with you, this is the priority, you're going to get this in. Okay? And then the exact opposite conversation's happening locally where they're saying, to hell with that important or that provincial project, we're going to do our thing locally. The thing that people have to realize is you have to find a way to do both. You don't have to complete one to do the other, but you do have to think about, like if you're on the OLIS team, the last thing you want to do is have local organizations deprioritize internal projects that are going to get them to the place where they can actually use the tools that you're providing. Okay, that would be a disaster. This is one of the things that we battle with in the SIMS land, is that a lot of these smaller organizations, the temptation for us would be to not invest in their local systems, registration systems, admitting and transfer systems, et cetera, and put the money into the e-referral type systems and the systems that are going to move the patients through. But we know, and there is no gray area, that if you have not moved the local processing, at least largely away from a paper-oriented environment, you can put all the electronic connectivity systems in you want, they're not going to be used. And we have tons of evidence of that. So you can't do one at the expense of the other, otherwise you won't actually be able to transform healthcare. I'm just going to flick down this slide quickly here. This is what we're hoping to get out of the SIMS partnership, and I'm not going to go through all of these bullet points. You can take a look at some of them if you'd like, but the thing that I would probably most call your attention to is the line at the bottom here that says a coordinated $30 million capital investment. The key word there is coordinated. So no organization has given up their right of autonomy of decision making. Each organization can choose what they want to do, but through looking at it through the two lenses of how do we build internal capacity while at the same time being able to integrate, you can coordinate some of this investment. And not surprisingly, when we look at the priority lists of these various organizations, what we've been able to find, examples of coordination would be that at one site they said, hey, we want to do patient scheduling, and we want to do patient scheduling in 06, 07. And this other organization said, hey, we want to do patient scheduling, but we want to do it in 07, 08. And we said, hey, guys, well, why don't we put you guys together? We'll implement first at one site and next at the other, but let's purchase and go through the entire process together, the system design, all of those sorts of things. Like, this is not really complicated stuff, but we had to be inside. We had to be part of their management teams to see where their priorities were in order to try to do that level of coordination. The other thing that I'll comment on this particular slide is that when we put this together, the slide's about a year old, and it was a $30 million capital investment over 3 years. The good news / bad news in this is that $30 million capital investment over 3 years has now grown to $90 million capital investment over 3 years, mainly because we've gotten larger, but also because success breeds confidence, and confidence breeds investment. So we're seeing more and more investment, which brings me full circle to my comments right off the bat as why I would hire as many University of Waterloo co-op students as humanly possible, because we're in the strange position of having resource and mandate and struggling to be able to staff it all. And I've already made offers to my friends from Grand River over here. And Glenn Cairns, who's the CIO of Grand River, couldn't join us today. His loss, because I'm now going to poach his staff. Hey, Glenn, when you watch this on tape, Glenn, you'll know what happened. Anyway, so this has been a big movement forward for us. I'm gonna switch views for a second and talk a little bit about sort of what we see going on a little more globally. I'll spare you that we're not going to go across the entire globe, but just a couple of spots and lessons that we've been trying to learn, or things that we've been trying to follow, and I'll talk about them on two axes. One is this issue of integrative initiatives versus internal capacity build. The other is the concept of centralized IT management versus decentralized IT management. And SIMS is a little bit of a hybrid in that we have one management team, but we march to the 9 agendas. We haven't made everybody have one single agenda moving forward. And I'm just going to try to walk you through some of the things that we've been seeing going on and what lessons we've taken from it. Certainly, the NHS is one that we follow fairly closely. A heavily centralized process, a very, very large investment, and depending on who you talk to, and I don't know if there's an NHS healthcare expert in the room, but depending on who I talk to, I hear great stories and I hear horror stories, depending on what's going on over there. I've been trying to convince my CEOs that the only real way for me to find out is I must go. I should go spend a good, healthy 6 months traveling around the countryside, finding myself and finding the answers to these things. They're not buying it at all. So these damn webcasts, I tell you. Anyway, so we've been watching closely what's been going on there, and we've seen some pretty good things, and see if we can get some lessons out of that. But again, a very centralized focus. Our sense is as well that they are trying to do both, build internal capacity and build the integrative. There are some inherent challenges in that, and it sounds like the integrative components are going quite well. The internal capacity are running into some challenges. But again, there may be some experts in the room who can help us understand it better. When we look to the U.S., and this is the second and last time that I'll refer to George Bush in my presentation, but George made these comments. Actually, I shouldn't give George Bush a hard time Actually, this is being taped, isn't it? I should probably just stop there. But anyway, I forget, and then it'll be remembered forever. Anyway, so George made these comments about computerizing health records at his State of the Union, which was really extremely encouraging. To have the President of the United States include comments like these in his State of the Union address is about the pinnacle that you could get. Unfortunately, we haven't seen a lot as a national program in terms of moving this thing forward. But in the U.S., what we have seen are some organizations who are doing some fantastic work. So although they talked a centralized model that we really haven't seen come to pass, in the decentralized sense of some of these large HMOs, we've seen some really tremendous examples of using eHealth tools to move things forward. The VA is one of my favorites. Sorry, I'm going to go back there for a second. The VA is one of my favorites. I didn't put in a slide that I really like, which is the VA taught us a very, very clear lesson about making sure that your eHealth investments, your IT, IM, whatever you want to call them investments, make sure that they're all put in a clinical context. Make sure that at the end of this, you can say, because of this investment, here's the number of patients who are receiving immunization who weren't receiving it before. Here's the number of medication errors that we've been able to avoid because of putting this in. And I think that these, pardon me, the VA group in particular have really been leaders in identifying how you fund eHealth programs and how they impact clinical care. Canada Health InfoWay, did you have anybody from InfoWay come here, Shirley? Yeah. You had, oh, fantastic. A great leader in Dick Alvarez, a tremendous program. We're all watching it very closely to see if it gets some funding in the next federal budget. If anybody's listening from Ottawa, we really think that it should. They've made some really great investments. This is a very decentralized and very Canadian-esque sort of way to do it, right? Is to find centers of excellence and give them some money and help them invest. And perhaps some lessons from the NHS in terms of being a little more draconian and a little more instructive may have helped. But certainly some good progress has been made with Canada Health InfoWay. BC PharmaNet has been another one that we've been looking at, which I think is a really great success story. Again, there may be some folks from BC who can tell us differently, but from the view from Ontario, looking at some of the things that have been accomplished through the PharmaNet program, again, more of an integrative initiative as opposed to a deep build or a capacity build. But we've seen some tremendous movement forward and taking some lessons there. And the drug side of what we're trying to do, there are just tremendous opportunities from a safety and quality perspective for moving the eHealth agenda along around medications. Capital Health, this again would be an example of that integrative kind of program. What I think is really attractive about what Capital Health has been able to do, and one of the things that we've been looking at, is taking a bit of a lesson from banking in particular, airlines a little bit, but certainly from banking. Capital Health resisted the urge to change all of their databases and change all of their systems, and instead looked at putting a web layer on top of their existing applications and providing information out, in this case, to the primary care docs, and creating a linkage between primary care and the hospitals. I think that's just brilliant. They could have spent an awful, and now they are spending some time looking at their internal systems and what changes they may want to make to those things. But if you think of the banks and what the banks have done, largely, a lot of their old systems are still back there running. Their old mumps-based systems are still sitting there. But what they've been doing is putting layers on top that are customer-oriented, that are providing real service back to the customers. And they call it many fancy names, but I think it's a great model for healthcare to embrace and understand. And I also think, one of the things that we see, and Edmonton, I think, did a fabulous job with this with Netcare, is don't wait until you've got the perfect product. The expression, perfection is the enemy of progress. If I think about my online banking, when I first started doing online banking, I could interact with my checking account, and that was pretty much it. And then I could see the balances in my loans and mortgages and all that sort of stuff, which was kind of depressing, actually, but at least I could see them. And But when I would do a transaction against any of them, you wouldn't see it in real time, right? The transaction would happen, you'd see it come out of your checking account, but you didn't see it come off of your Visa card or whatever it was that you're paying. Over time, all of these things are progressing, and of course now you've got wonderful tools, so you can calculate your net worth, which also comes out as a big negative, right? So it's depressing, but it's useful, right? Which is maybe another lesson in healthcare. But anyway, Netcare embraced some of those principles, and I think it's important that healthcare embrace them as well. And Dominic and I were chatting about this just today, and the term that I use, we were talking about e-referral programs that we're trying to move forward with, and largely, I feel, and it might be a bit harsh to say, but we're sort of bumbling our way through it a little bit. We're just kind of figuring out what works as it goes and keep moving. But that's probably okay. Now, what we were chatting about is you need to find the opportunities to go back and be a bit more reflective and a bit more studious on some of the things that you're doing. But you don't have to get it perfect before you introduce it into your environment. And that's been the way that we've been doing things within SIMS. Ontario gets a pretty bad rap when it comes to eHealth in this country. We're not as bad as everybody claims that we are. There's some very, very good things going on. And one of them that I pick on here is the Neon Group in northeastern Ontario, and they've done some fantastic work up there and really should be applauded for that kind of work. The other thing that I will get on my little hobby horse on for just one quick minute on this issue of particularly what's gone on in Ontario, we have to recognize that Ontario now with the LHINs are only starting to move down the path of regional services. And one of the challenges that I face in the SIMS environment is I go in front of these hospital or healthcare agency boards, and these boards, rightly or wrongly, view themselves as having a fiduciary responsibility to their organization, not to the community, not to population health and public health. Their duty in their minds is to their organization. And if they've got a healthy organization, then that is the best way to serve their population. This is a big challenge. A lot of the programs that we're putting forward introduce risk to their organization without a clear and demonstrable benefit back to that organization. Okay? The benefit is back to patient care. The benefit goes to the client and to the population and to the region, not necessarily to their organization. But the risk is incurred at their organization. So this is a bit of a challenge. And in the 90s, and Dominic, I don't know if, Dominic, you were in Ontario back in the 90s or if you were out west, but in Ontario, the organizations were incented, boards and management were incented to think autonomously, okay, protect autonomy. Many of the system decisions that were made back in the 90s were specifically made with the lens of protecting autonomy of their organization, not in integrating into other organizations. So I think before we say that everybody in Ontario are a bunch of idiots, we may want to look at what was the set of incentives that were in place when these decisions were being made, and then what are the set of incentives there now, and what kinds of decisions are being made in the last couple of years. And I think that with the LHINs, I don't know how much the LHINs have actually, in fact, changed business processes and business decisions in healthcare, but certainly they've signaled a new environment of where the government would like to go, and healthcare organizations, by and large, are starting to respond to that. And you have organizations who are talking about sharing. Even within the SIMS partnership, there's certain organizations in there who 2 years ago, there's no way we would have been able to do what we're doing here, but we're starting to do now. But the Neon Group is a great example in Ontario that's moving forward. I put University Health Network in only to illustrate from a, not necessarily from an integrative, but more on a build capacity, that first circle. But one of the things that we forget about is that University Health Network is actually 3 hospitals, 3 distinct hospitals with distinct cultures, distinct programs, and they've been fully integrated onto a common system. And that would be for PACS, for images, for data. They're all moved onto a common system across 3 hospitals. They just happen to have a single governance. I think we forget that sometimes when we're thinking about Ontario and how little we've done in Ontario. You know, they had 3 different health records departments and 3 different MRNs, and all those challenges that we're faced with out west at the University Health Network. And I'm not applauding myself, by the way. Most of that work was done before I got there. So, but a lot of work was done to integrate 3 different hospitals and put them together. Montreal is doing some fantastic work as well. They've got a network of 8 hospitals developing a single EHR. So here, again, a lot of building internal capacity amongst these hospitals. The last one, as I did my little span so subtly from West Coast to East Coast, is Nova Scotia. I was actually just trying to disprove the theory that people in Toronto don't know anything that goes on outside of Toronto. Although I do have to admit, on my way out here today, I got lost and ended up in Burlington. So how I ended up in Burlington, and you know, the really sad part is I didn't really know where Waterloo was relative to Burlington. I just knew that Burlington and Waterloo are not the same place. That's the best I could come up with. So I started phoning around trying to find somebody who could tell me how do I get from Burlington to Waterloo. And sadly, in the people in Toronto, I had to find a Waterloo grad. I'm not kidding. I had to find somebody who used to go to school here. Because most of the other people, the Torontonians, none of them knew. They knew the same as me. Burlington and Waterloo aren't the same place. But other than that, they didn't know how to get here. So some Waterloo grads helped me out. So Nova Scotia, and this is a tremendous example, much like Neon Group, and probably one of those, the other cliche of the what's the necessity is the mother of invention. Is that close? Anyway, in Nova Scotia, they had the good sense to realize that as a province, they're way too small to be purchasing IT applications independently in each organization, and they've done a provincial play that has been very successful, at least again from a Torontonian's perspective. So I'm just going to go through a few slides. I've got about 10 minutes left or so, and then happy to take some questions. Just in terms of some of the future drivers that we're looking at as we move forward, I'm not going to go through each one of these things, but I did want to highlight a few things that are a challenge or an opportunity. And I know we've got some salespeople in the audience, and I'm sure that Ron Dunn from McKesson will tell me that any challenge is an opportunity. And so there we go. That's right. So here's a few things that are trends that are going on, particularly in Canada, that we're trying to get a handle on as we move forward. This idea, I put the word standard of care up there, is really having a longitudinal record is becoming, certainly with what's going on out west, is becoming and will become the standard of care. It won't be much longer that patients and clients, consumers of healthcare, are going to be satisfied with the idea that for them to get their record, if they want to understand what's going on with their record, they've got to go to the UHN website to get UHN's information, and then go to the Sunnybrook website to get their information from there, and then the website from over here. And of course, right now they can't go to any to get their information, but they won't be satisfied with that, and they won't be satisfied with going into their physician's office and their physician not having access to their information from their stay back in the hospital. And certainly, the folks out west are raising the bar for us in Ontario from this perspective. Chronic disease management, for a layperson like myself who is a wannabe economist, this thing speaks to me. Like, it looks like a tremendous opportunity for us to be focusing our strategies around chronic disease management and spending time helping to keep folks with chronic diseases out of the hospital and under good care out in the community. When you look at the numbers, it's pretty staggering. When you look at a lot of the literature, there was a recent study done by the RAND Corporation, very good study done looking at the value of this, and the scale of dollars was just astronomical. We did a little study around chronic disease management. If we were to put in a chronic disease management model in Toronto around diabetes, and if we were to get only 50% compliance, for every dollar we would invest, we would save 6. It was just an incredible number when we looked at, particularly the savings, of course, coming from keeping people away from getting into kidney failure, amputation, blindness, other things that have a very, very large cost. Computerized physician order entry, an interesting one. I'd be interested in the group's thoughts around why the safety agenda has not gotten the profile that the access agenda has gotten. There's certainly a lot of information, perhaps even better, one might be able to argue better information about the quality and safety issues in our healthcare system, and yet, it's just yesterday on the front page of the Globe and Mail, the headline was, cancer wait time promise broken, or whatever that, vow broken, whatever. But yet we had these reports. There was a wonderful study done out of the University of Toronto. Am I allowed to say University of Toronto here, Dominic? Is that okay? It wasn't as good as a study if it had been done at Waterloo, but it was a not bad study. And the thing that was amazing about it was that when the report was published, it did make the Globe and Mail, but it was buried in one of the sections in the middle of the Globe and Mail, right? And the only thing I've been struggling with why the safety agenda doesn't get the profile that the access agenda can get. And perhaps the most instructive thing that I ever did was I asked my dad why is he not worried about this, and yet he's all upset about access. And he has no chronic disease, but he's just the type of person who likes to get upset about things. And his answer to me was, well, that's because that's happening to someone else. Right? That's not my doctor. My doctor doesn't make those kinds of errors. When I go in for care, I get great care. It's someone else, those poor suckers who are getting this bad care. So maybe there's some of that phenomenon going on, or maybe we just haven't communicated well. I don't know. Certainly in the hospitals and healthcare agencies that I work for, safety is top of mind and is going to be a major driver moving us forward. Telehealth is a great advance. I don't think I need to preach to you guys about the value of telehealth and some of the things that we've been able to do there. We've got a couple of slides on it. Certainly areas outside of Toronto have taken greater advantage of these tools, but we are looking at how we can do it. One of the things that we have done in Toronto was we did a program called Urban Telehealth. And we came to the realization that most of the organizations in Toronto were hooked up to the North Network. And we started to look at the transfers that happen between organizations just within Toronto. And there's a lot of issues around these transfers. They're different issues. It's not so much weather and distance, but it is congestion, smog, traffic, all of those issues. And what we started to do was we had a few consults done for patients who had recently had a lung transplant. And they would go to St. John's Rehab, which is at the northern part of Toronto, up at Bayview and Steeles. And then they would do the consult with the transplant specialist down at the Toronto General Hospital, which is right downtown. And the patient loved it. The physician was also pretty happy about it, but the patient really loved it because they didn't have to fight the traffic. And most importantly, this was in the summertime. Talk about in context. This is in the summertime during a smog alert. This patient just had a lung transplant. To not have to bring them down into that environment and leave them up at the top of the city really was great. So there's a lot of potential around telehealth, and Ed Brown and his crew have done an amazing job moving that agenda forward. But my belief is there's still an awful lot more we can do with it. I do a little plug here for the University Health Network. We have the Center of Global eHealth Innovation. It's a lab that's on our 4th floor of one of our new buildings. The main reason I put this up here is not only to plug the center, but to also talk about this concept of testing and studying and understanding what it is that we're doing. We are moving at a very, very rapid rate. It is a relatively young industry. And doing some studying and creating metrics so we can understand some of the things that we're doing would be to our advantage for sure as we get into long-term improvements. One of the things I will comment on in the far left there, you see we've set up a mock OR. A thing that was truly amazing and was kind of my lesson. I became a convert around human factors engineering. I don't know if there's a lot of human factors engineering going on at Waterloo, but up until that time, I sort of thought of it as a little bit of hocus pocus and a nice idea and all that sort of stuff. We had, our anesthesiologist had wanted us to buy an anesthesia system for them for a very, very long time, and we kept putting them off. We finally agreed to do it, and we got them into the project, and we did the short list, et cetera. We brought the software into our lab, and the anesthesiologists, after about 3 weeks of using the software, decided to turn off the project. They felt that through the engineering, the human factors engineering and the studies that we had done, they were uncomfortable with the level of safety associated to the software, to the two vendors. Neither was McKesson, by the way, Ron, so you're all right. And the anesthesiologist said, we're not going to proceed with this. That's the politic of an academic health center. For these anesthesiologists who have been waiting 2 years to get their project funded, and then for them to say, no, we're not going to move forward with it, that was a huge, huge thing to do. And really sort of illustrated for me the value of doing these kinds of testing in these kinds of settings, so we really understand what it is we're doing when we're turning on computer systems. A couple last slides. So our patients, some motherhood statements here, but really where we think that the future is going, the idea that patients are well informed, and more importantly, that they're active in their care, that we have support systems in place, and that they actually have a comprehensive set of information that they can refer to. a system. I don't know if you guys know this, but there's some challenges around our ERs right now. Are you familiar with that situation? So when I was picking some examples, I thought that one might ring true to some of you. Anyway, but how are we making sure that the people who are going into our ERs need to go into ERs? I had a wonderful, I can't remember who said this to me, but the comment was one of the major problems that plagues the healthcare system is that right now, in order to find out whether or not you need to see a doctor, you need to see a doctor. So, what can we do to try to change that environment a little bit and move it forward? And I didn't bring them with me today, but we've been spending a lot of time working on the emergency rooms and how do we ensure that the right people are going to the emergency rooms. And I have to say as well, I want to rush to the defense of our ER docs. I don't know about the ER docs out here, but certainly the ER docs that I interact with back in the city of Toronto, they care an awful lot about their patients. And their thing is not so much that they don't want people to come to the ER, but they are also big on, but how are we informing the patients so that they know whether or not they should be coming to the ER? And if they can't come to the ER, they don't want them staying home getting sicker, right? There have to be other support systems out there for them. One of the things that we've been doing is looking at how do you use the community, the CCACs, better. They have access to a lot of home resource, taking care of people in their homes, providing them with greater comfort. The patients like it an awful lot better because they're at home in a comfortable setting, and we keep some of these folks out of our ERs and so that only the people who really need it are finding their way into the ERs. The other one, the last point that I want to pick on with critical care is more just to talk about the concept of us knowing that the healthcare system will be there when we need it. We saw some instances where it wasn't so there when we needed it. Certainly SARS put the health system under stress. And if this was a different group, if we were talking about IT, one of the things that was really interesting for all of us, and speaking just solely for my group at the University Health Network, we had all of our disaster planning in IT was all based on the concept that the health system kept functioning and the IT system failed. We had never really thought about the scenario where the health system was actually the thing that failed and the IT system was fine. It created a huge change for us in terms of what we had to do to support that kind of environment. But how do we ensure that we've got a health system that's there when we need it moving forward? And certainly just spending more and more money on it is not the way to do it. My second last slide, this is a scorecard, and it's very, very fine font. This is what I do with my CEOs, you see. If I make my deliverables too small, and they can't really hold me to them. But the only concept that I want to put forward here is, again, how do we make ourselves more accountable, particularly for our eHealth investments. There's no reason why eHealth investments can't be done in such a way that there is accountability for it. Rarely, and perhaps I've just been a good salesperson to all of my CEOs, but rarely do we look for financial returns off of IT investments in healthcare. Largely, the areas where you can get financial return on a lot of these investments, like in human resources and in finance departments and in health records departments, all those transaction-oriented shops, we raped and pillaged those badly back in the 90s, right, in the slash and burn days. There's not a lot, and if you look at the studies, the benchmarking studies that are done across Canada, there's just not a lot left in those finance and HR and health records department. Health records maybe, but the other departments not so much. So financial returns on these IT interventions are difficult to do, but certainly measuring what has been your impact on safety, what has been your impact on access, those things you can definitely do. My last slide is the slogan that we use in Sims land from that great health informatician Mario Andretti. But we do try to push these things, and this pretty much describes our environment. So anyway, I want to thank you very much. I think that's the end of my talk, and I'm happy to take any questions.
As we bring the microphone to you, so you have a chance to make comments, or I know you've asked people to comment on a number of things throughout your talk, so it's not just questions, your own thoughts, your own concerns. Give people a second, but I'll ask you one. You mentioned in your talk e-referral, and could you give us some idea of the nature and magnitude of what's involved here?
Sure. Thank you. So the things that we've done so far, we've looked at how do we refer patients both programmatically and sort of functionally. So we've looked at, for instance, the stroke network, and we've had clinicians get together to define out how would you refer a stroke patient through the system, both at a primary care level, through the acute care setting, into rehab and continuing care, and then back into their home again. We've also looked at it functionally, so we've looked at how do we move referrals, for instance, from an acute care setting to a community setting. We've had our various referral programs up, not including the stroke network because that started before us, but the programs that we've run, we've had up and running now for about 9 months. We've done, order of magnitude would be somewhere between 5,000 to 7,000 referrals electronically through these systems. And I think we're barely the tip of the iceberg. This is a huge new world for us. This is the application of all of these wonderful tools. You know, the electronic health record is an important foundational piece, but in and of itself doesn't change the way care is delivered. Referral management and resource management is really critical. It gets a tremendous amount of buy-in and support. There are other parts of the country who are doing some very fascinating things around e-referral, but I do believe that we are just at the tip of the iceberg. Every one of these referral patterns have very important, unique elements to them. So the set of information that you would include in a referral for somebody who's just had their hip replaced is going to be very different than the set of information that you would include for somebody who has just completed a lung transplant and is moving up to a rehab facility. So it's very complex looking at this stuff. Generally, we've used pretty finite demarcation points, and we have not put a lot of intelligence into any of these systems. So we just do a basic referral. We have put some algorithms in, some basic algorithms. So for instance, when we look at somebody who's had a hip or knee replaced, there's an established algorithm as to whether this patient should then go to a rehab setting or go into the community. So we can put some of that stuff into the referral, but generally some pretty basic intelligence to this point. Largely, if anything goes wrong, the system just stops and says, you know, back to manual. And we get a report back on how many referrals. We would show that as a referral that was not completed. And then we can follow up to find out why was that referral not completed. First off, the technologies that we've been using have been pretty inexpensive. We spend most of our time on process redesign. It's much more about process redesign than it is about IT when you get into the e-referral. We've used, I can ingratiate myself to my other sponsors from RIM. We've used Blackberries in this because they're cost-effective devices for us to be able to send messages to, which has worked out very well. I can't find a plug for you in this one, Ron. I'm sorry we haven't used McKesson and any of these things yet, but we'll work on it. But I do think this is just the beginning, and we're going to need to figure out how we're going to tackle this because we can't do at least what UHN has been doing with its partners, with the Toronto CCAC. Toronto CCAC in particular has been leading the way. We can't, every time we go to do a referral, start from scratch and say what kind of technology we're going to put in and what information are we going to flow. It will be way too expensive. We're going to have to figure out a way to do this, but also engaging the clinical leads to help us understand what information needs to transfer. And the other thing we need to do is then work with the folks, for instance, from Grand River to say, if this is the set of information that, when we're doing a referral around a mental health or addiction patient, is this the same set that you would use, right? And hopefully the answer is yes. And so far, we've seen that the answer is typically yes. So there we may be able to build through economies from that fashion. But I think it's a brand new world for us.
And looking at your LHIN, you seem to be bringing in everybody. And yet in other areas, I see groups being left out. Now, is there any legislation that governs this, or are you just welcoming everybody with open arms and figuring out how to integrate them into the system?
Yeah. So the answer is both right now. Strictly speaking, there is legislation that would govern this, which is the LHIN legislation. And the legislation that has been put forward, any integration activity between healthcare organizations within a LHIN falls under the jurisdiction of the LHIN. So the LHIN can initiate integration, it can prevent integration, it can instruct integration. No LHIN has done that to my knowledge yet. They're allowed to issue orders that would say you can do this or you can't do that. So right now, we tend to just be doing it on a basis of whoever wants to join in can come and join in. I think that at the Toronto Central LHIN, we're a bit unique because of because we have acute rehab, long-term, and community care. We don't have primary care to a large degree. But there are other LHINs, for instance, the LHIN just to the west of you, I believe London's to the west. That LHIN, the acute care organizations are really doing some amazing work, far better than what we're doing in Toronto around the acute care, and so on. Kingston, Ottawa, they're starting to move. But most of it is sort of a bottom-up approach of finding organizations who are keen on working together and then working things through.
Thanks very much, Matthew. I'm from a LHIN, and I come with a bias or some baggage of a technology management approach. There's several genres of technology, not just IT. Mm-hmm. I feel if you ask hospitals what's their technology strategy, they'll give you an IT strategy. Mm-hmm. They won't give you an overall technology strategy. But I know UHN mm-hmm. has, as a platform document, it has a very advanced approach towards technology genres and the integration of those and the integration of platforms. Mm-hmm. Are you able to talk about that, the concept of integration technologies, whether it's nanotechnology, biotechnology, robotics, or whatever? Sure. Because you seem to have taken that step where the other hospitals, even the teaching facilities in Ontario, mm-hmm. have not.
Yeah, thank you. An excellent question. I actually have to credit my previous CEO at University Health Network, Tom Clausen, for where his head was at. He came to me a number of years ago and suggested that we create a technology portfolio that included medical imaging, biomedical engineering, IT, with the concept, by the way, this is all under the English major, right? But the concept that the line between a computing device and a biomedical device is very blurry. And it's going to get even blurrier as we move forward with this stuff. Most of the time, when we work with the biomedical engineering folks, they're buying computers. Many of these devices, they may not look like a computer, but they're basically a computer. Many of them now have IP addresses, etc. So we've been trying to take a more holistic approach to the concept of technology and where would we invest in this. And this is particularly important in the academic acute care areas. But it still translates very nicely into some of the areas within rehab medicine and long-term care and community medicine, particularly when you get into the concept of patients on chronic ventilators out in the community, of which I was stunned to find that in Toronto alone we have 2,000 patients using ventilators at home. And right now, I don't know of any program that manages them as a technology resource. And how are we actually managing that? I don't know. There is a tremendous initiative underway called I know the short form for it is ITAC. I'm not exactly sure what it all stands for. But it has clinical leadership on it, looking at many of these issues of how do we bring technology, all of these technologies in better view of where we're going systemically. And in fact, I was just talking with Dominic this morning about working with the University of Waterloo to experiment some more and understand more where is this going to go, because we believe that these devices should definitely be writing into the electronic chart.
Another bias, or just a suggestion, I'll shut up, is if you're working with Waterloo, why not involve Dominic and the management of technology division in the engineering school, mm-hmm. and in McKillop, the resources, I think, at this university and the integrative capacity, to me, presents an opportunity that would have considerable innovation to it.
Yeah. I agree with everything you said except Dominic.
Oh, hi, Karen Bell. I'm the project manager here at Grand River for the CCIS, one of the 10 lead pilot sites rolling out across Ontario. And you're our project lead, so nice to see you.
Yeah, nice to see you. Another person we're going to steal. I have a contract over here, job offer for you, right? So you can...
I was also involved in we were one of the 5 beta sites for the rollout of the WTIS, and we're also implementing I hope to be one of the lead implementers of the ORBC, the Surgical Efficiencies platform. And I just want your comments on how looking at it from as a management perspective and a business perspective, and once these are all linked, how would Grand River, I guess, as an organization, take the information from the CCIS, from the ORBC, from the WTIS, and make some clinical and capacity decisions around that?
Yeah. I don't have a great answer for you because, well, we're just sort of sorting through that stuff now. Because it has grown rapidly and has grown with a very project-specific sort of environment, we need to think about how are we going to bring this all back. Is it all going to go into a single database or a set of databases, that sort of thing? What we're trying to avoid, which is the path that we're on right now, quite frankly, is that for your CEO to understand what's going on in Grand River, they would actually be looking at 3 or 4 pages of information. You know, here's my wait times on this thing. Oh, here's what it looks like for critical care. Oh, here's what my surgical efficiency is. Each of those programs have been are building in the capacity that you within Grand River would be able to access those data sets. We're just having some discussions now on, well, how do we create an environment where you wouldn't have to go to 3 different data sets to pull that information and do it locally? Can we do that at a provincial level? I'm not 100% sure that we're going to be able to, but that's where we'd like to go with it. Okay? Thanks.
We have a question in the back from the network.
Yeah, it's from Jillian Piwoski from South Area Hospital. She's asking, is it the intent of the SIMS partnership to share back office services or just clinical applications? And also, could you also comment on patient portals, home care, eHealth initiatives?
Okay. First on the back office, there's actually an initiative underway in the Toronto area around back office that predates the SIMS partnership and includes pretty much all of the organizations from within the SIMS group. So we probably will not get into that. We'll be supporting it on the hospital and the healthcare agency side. So hopefully that answers the question. We won't create a new initiative because that initiative is already well underway. It's called HBS and is going well. In terms of from the LHIN perspective on, it was patient portal and, was there another component? And home care. Okay, great. So home care, eHealth initiatives, and patient portal. First on the patient portal, we actually are working with Grand River we got some support to move forward with defining a patient portal. Patient portal, to me, is very much like the discussion we just had on e-referral. First, I think there's a tremendous opportunity there. It's a relatively greenfield opportunity. But we definitely need to think through what exactly will we do with patient portals. And I think our friends from Grand River have shown us a great lesson there with what they've been able to do around the oncology portal. We do know, the things that I know anyway, I think I know, are just slapping up a bunch of information, including laboratory results and all that sort of thing, is not particularly useful. So we're trying to find ways, and right now we're approaching it very much to the way that I described the e-referral, where we would look at it from a disease-specific approach, which is, and this is Grand River who showed us this with oncology. We're now looking at chronic kidney disease. We anticipate we would do the same thing with diabetes. So how do you build out a set of information for people with a specific, within a specific program or a specific disease group that would include the information from their chart as well as the educational materials and other resources that would be necessary to support them. The LHIN aspect of all of this is we'd really like to have one place so that patients or clients are going to a single place to get this information. And one of the things that we found was that there's, not surprising I guess, is that there is a bewildering amount of information available on the web for these various types of diseases, all the way from very local information of support groups to very complex information in terms of understanding the medical condition that you're experiencing. But nowhere was it being presented holistically in a way that a person could understand both, you know, what is my treatment program for breast cancer, but also where is there a local support group that I can go to for support for breast cancer survivors. So those are the kinds of things we want to look at with respect to patient portal. Again, I think, like e-referral, it's huge. Pardon me, it's huge in terms of the opportunity. On the LHIN home care front, pardon me, there's a lot of challenge in moving forward on the home care front within the LHIN, mainly because if we go back to my 2 circles, that first circle of IT capability is very minimal, largely speaking, in many of the home care agencies. We are trying to advance that, but what we looked at in particular was how do you do some of these integrative programs like e-referral into home care agencies and resource management. And one of the things that we found was that many of these community services, if I can characterize it in that way, have already organized themselves to provide support to the acute care sector, but they had no IT infrastructure to enable that. So as a LHIN, what we're trying to do is look for where they've organized themselves, where the community has organized itself, and then can we go and acquire IT. My throat is giving out as I'm speaking up here. Pardon me. Can we go and acquire IT to support those changes that are already going on in the community services?
I told you we should have put vodka in that instead of water. Really help. I just want to put one of our questioners has made the point about the management of technology program, and it is a real resource here. It's quite a program, both locally and remote capability. We also have a chair, isn't Laurie Curtis? There's a chair in health technology assessment in the Department of Economics. So we have quite a large number of people here who are interested in technology assessment and have got a real track record in that area. I'll make sure people, if you put your hands up, I'll get a question. One question, my favorite question, is this capacity problem, the people. Now, you're getting 20 Waterloo graduate students, co-op students, but what do you see as the issue? It's been pointed out we need thousands of people related to health informatics. You know, how are we going to get that? What do you see as the challenge? How important is that? Anything you can bring to the table with regard to the getting those people in place, training them, getting them in place, and then using them?
Yeah. It is, I don't have a great answer on that one. Right now, and certainly not a systems-oriented answer. We are taking a very competitive approach to it. These people think I'm kidding when I'm saying that I'm offering you jobs. If you come to Toronto, I offer you a job. Unfortunately, right now, it is a competition. I think that for us as well, we're trying to make sure that we can keep people. Not only can we recruit them, but can we keep them? I think that co-op programs like Waterloo's, we have our friends here from Conestoga College, the University of Victoria program. The more that we can incent these programs, and the more that different disciplines understand you don't have to be in health informatics to be interested in the kinds of things that we're doing. Certainly, we use a lot of engineers. We use MBA students. Biz Science is one of the programs that we attract a lot from at Waterloo. Even lowly arts graduates can find a place in some of the things that we're trying to do. So much of what we're trying to do is change management, which is an overused term, but so much is working with people, right? It's amazing. The woman that I just recruited from the Ministry of Health to be a director said, you know, she would never have imagined that she would have been a director in an IS group, okay? Because at the end of the day, that's what we're thought of. But the reality is that, I mean, for myself, I very rarely make any kind of IT decisions. In fact, I never make an IT decision. I do make business decisions, and I do force our IT people to present to me in a way that is a business, because usually it's a business decision that needs to be made, not a technology decision. We're not developers, so we don't get into that from that perspective. So I think we have to be a bit creative. I think we also have to sell a lot better. We've had comments recently, both when we do our co-op program, but also when we do our recruitment at fairs and that sort of thing. The number of people who are coming to work for us who say, I never would have pictured myself working in healthcare. Okay, so in their minds, you have to be a doctor or a nurse. That's the job in healthcare, and not understanding how many things there are in the healthcare field, and giving that an opportunity. So I think as programs, as universities publicize their programs better, but also the healthcare provider agencies do a better job of advertising themselves and making people understand that, you know, a lot of the principles that we're looking for apply to healthcare as much as they did in the industry that they were working in previously. So I think we have to be creative. The other challenge that makes this really, really difficult for us is the fact that, you know, the people that we really like to recruit are nurses. We love recruiting nurses. Of course, the problem is that there's a nursing shortage, right? So the CEO of our organizations they are not all that pleased when it's a zero-sum game for them, right? You take somebody off of the clinical unit to come and work with us in IT, but now they have to replace on that clinical unit, and the shortage of nurses is just as bad, if not worse, than the shortage of IT and health informatics professionals. So it's going to be a long slog as we go through this, and until then, we'll be a bit competitive.
I will be really upset that this is the second pitch you've made to Claudette today, so it's really in danger. Could you go back to slide 19? Can you quickly go back to your one with the, if you can find it easy or not. Keep going back. It was the thing with the little pies on it, pie charts. And that one. Now, maybe others in the audience and whatever can say, I found this amazing that the percentage of days of consultations for young people was much more than older people. Have I gotten it wrong? Or? Yeah, but 80% suffer from chronic diseases. And look at the amount of use, if that diagram is correct, that they have compared to the young people of a much higher level of use. I wonder what this says exactly, that
yeah.
I thought that, I don't know, have you ever reflected on this yourself? Or?
I actually didn't pick up on that nuance there, Dominic.
Well, it's just an interesting reflection, and maybe it says something that the consumption of healthcare within this group is younger group is really where some of the major issues are. And
one comment we'll make reflective of this is the challenges that this puts on the healthcare system, in particular, challenging some of the roles that we traditionally think healthcare workers play. And one of the examples that I had was a specialist, a cardiologist, saying that basically now many of their patients in his outpatient clinic come to him for primary care purposes because there are so many medications, and they made the sort of not so comfortable comment about how years ago they'd be dead by now, right? So now they're alive and they're on multiple medications, and they're coming because they would come once a month anyway. They're starting to come and bring their primary care issues to them as well. So we're really starting to see a shift in traditional roles based on some of these disease challenges.
Well, very interesting. Any other questions or comments by anyone? Okay, there's one here.
I thought that was a really fascinating talk, and thank you for that. I'm actually somebody who's relatively new to the healthcare space, and I came from supply chain management. And just sort of two observations. One, there's a lot of similarity between the sort of tension between trying to do internally integrative projects, capacity creating projects inside your own four walls, and at the same time integrative projects with the other organizations. And that's, it looks to me like a supply chain problem.
Yep.
Typically companies would have to deploy business systems internally before they could be good participants in a supply chain. Yeah. And they're competing for dollars when you're trying to do both at the same time.
Yeah.
One thing I would say, and I think it speaks to the importance of succeeding in some of these areas, is stronger success in collaborative efforts, supply chain efforts, or just collaborative even inside a single organization. Mm-hmm. If we do that better, we'll better utilize our capacity, and it has the illusion of creating capacity. Yeah. Now, right now, we have a lot of people doing a lot of effort that doesn't lead to the outcomes we're looking for, but it does consume their time and cost money.
Yeah, yeah. Excellent observation, and I would say that it not only creates the illusion of more capacity, it creates more capacity. And we've been surprised by how much underutilized capacity there is in the system, because when we look at the way that it acts right now, the healthcare system, it feels like it's way over capacity. And largely it is, but there's pockets in there that are well underutilized. And through tools such as the e-referral, and again, just to pick up on the e-referral, right now one of the limitations of what we're doing with e-referral is I know Ron, and Ron knows me, so we set up the system, and now I'm just sending an electronic thing to Ron, okay? In where we want to get to, which is going on on Vancouver Island and in Calgary, is what I didn't know is that Ron, these four people here all provide the same option to me that Ron does, right? So when Ron, up until then, if Ron's shop was all filled up, I assumed that I can't get a bed, right? Now we're getting people to register into the computer system, so now I'm aware there's actually availability in some of these other centers. But without some way of prompting that, I as an individual would never have known it.
I'm not supposed to talk about the mic. I mean, that was exactly, that's a classic case, and it's queue management.
Mm-hmm.
And quite frankly, they were able to create a 60% reduction in queues in the NHS when they started going to choose and book and saying, you know, you're not doing this one-to-one, point-to-point, and everybody wants the guy who's busiest. You're going to say, listen, this is the service that I need, and here's the range of people, and it's like at the bank. You join a single queue, and you're served by the first one that's available to serve you. They reduced their wait times by 60%. They didn't hire any new doctors. They just managed the ones that they already had more effectively. I think there's a huge, huge opportunity to be more systematic. Call it a healthcare system, but frankly, a lot of this is ad hoc.
Yep, absolutely. The other piece that we found is that a lot of the inefficiency also comes from just incomplete data. Right? So we contact Ron, and then Ron says, oh, sure, but oh, by the way, before I can accept this person, I need the following bits, and now that's another. So it takes 2 or 3 transactions to do what normally should have just taken 1 transaction, for sure.
It's interesting. We've been dealing over the last year with Mike Connolly from Smart Systems for Health, and he's conceptualized the health system as a resource management problem. He came from forestry management, and so there's so many parallels that we could take advantage of. So I'm waiting for the outcome of that work. It's been a long time coming, but I'm very much looking forward to it. I look forward to having you here. I've unshamedly said you're the best CIO in the province, and you have unshamedly said only the province. But I mean that. I hear a lot about many people, and uniformly, I hear nothing but good things about you. So either you've convinced a lot of people to lie all the time, or you really deserve the accolades that you get. And I'm hoping that you'll be one of the best before 60 as well. And there's no hope for me anymore. So I might as well give it to you. I also think you've warmed the cockles of Kathy Schreier's heart from the English department, and that you graduated in English, and she's working in health informatics, by the way. And so somebody just proves it can make it right into the field, not just peripherally. You know.
Moving on, Dominic.
Thank you very much for coming. We really enjoyed it.
Thank you. Thanks very much.
Well, first I'd like to give a small token of our appreciation. So thank you very much for coming. And I guess the last thing that we have to do for the series is to give out the last BlackBerry for the series. So I have to thank our RIM sponsors for providing a BlackBerry at each of the seminars this year. It has been wonderful. We've really appreciated it. They're both at the back, Fraser and Sean, so thank you very much. And maybe I can get Matt to help me here. Now, Matt, the rule is that you have to be here, and either here in person or on the web right now in order to get a BlackBerry. So we may draw names of somebody that registered but didn't show up. So we may have more than one possibility. So don't give up with the first name that is selected here.
Matt Anderson. I really wanted a BlackBerry. Jeff Potts.
Oh, he just left. I saw him leave.
Is that the person who's sitting there in the... Yeah, see? Shame on him for leaving.
Oh, that'll teach people to leave before the end. Oh, I mean, the heartbeats are going, right?
Right. Josephine McMurray.
On the web, here.
Oh, look at right there.
Yay! All right.
They all say Josephine McMurray.
So you'll notice that there's something that we have. All right. Well, thank you very much, and thank you again, Matt, for being here. I've enjoyed every one of our series. I've learned a lot, and I think everybody has. So anyway, we'll take a break over the Christmas holidays, and we'll see you in January. So thanks a lot.